I'm Randy Lowen, a critical care paramedic with Orange, and today we're going to demonstrate the occasional cricothyrotomy. Preparation is key to a successful cricothyrotomy. First, clearly announce the can't ventilate, can't oxygenate situation and delegate continued attempts to oxygenate and ventilate the patient to another team member. Don appropriate personal protective equipment, including gloves, mask, and eye protection. Gather the necessary materials, including a 6-0 tube, a bougie of whichever type you have, a number 10 scalpel, chlorhexidine swab, and a 10 ml syringe. A commercial securing device is helpful as well. And then your BVM with your regular end-tidal CO2 and HME filter. Ensure the endotracheal tube balloon is tested for leaks by inflating it and then completely deflate it to facilitate insertion. Lubricate the distal end of the ETT to ease its passage through the cricothyroid membrane and into the trachea. Lay the patient flat and gently hyperextend the neck to maximize exposure of the cricothyroid membrane. Landmark the cricothyroid membrane with your non-dominant hand. A helpful technique involves placing the thumb and middle finger of your non-dominant hand on opposite sides of the thyroid cartilage and your index finger on the cricothyroid membrane. Prepare the anterior neck with chlorhexidine or other antiseptic solution. Hold the scalpel in your dominant hand, resting your elbow on the patient's sternum for stability. Make a 3 to 5 centimeter vertical incision through the skin over the cricothyroid membrane, cutting from just below the thyroid notch to the cricoid ring. You maybe need some more incisions to get through the tissue, depending on what tissue you have, until you can positively identify the cricothyroid membrane. You're going to do a horizontal incision through. You're going to sweep both sides to dilate the hole. Remove the scalpel and discard safely. Once confident you're in the tracheal lumen, use your dominant hand to pass the bougie into the trachea, approximately 10 to 12 centimeters until it stops or meets resistance. You may feel tracheal clicks. Have an assistant railroad the 6.0 endotracheal tube over the bougie until the balloon is just inside the trachea. Be careful not to unilaterally intubate one of the lungs. You're going to inflate the cuff, confirming that you got good pressure in the pilot balloon. You're going to remove the bougie and connect your BVM. And then we're going to listen to the lungs and the stomach to confirm we have air entry in both lungs and negative in the stomach. In most cases, it is recommended that the operator simply hold the 6.0 endotracheal tube in place until we can get the oxygenation and ventilation under control. Once corrected and relative calm is restored, secure the endotracheal tube. Sean, I'll just give you that there to ventilate with. Secure the endotracheal tube in place using sutures, tape, or a commercial securing device. A large amount of endotracheal tube will be left outside the patient. Consider cutting the tube or securing it along the neck to prevent kinking or dislodgement. Initiate usual post-intubation care, including sedation and titration of ventilation. Following the procedure, obtain a chest x-ray to confirm endotracheal tube placement and rule out any complications. And there you have it. The surgical airway is a rare but life-saving procedure with appropriate training and equipment. It provides a great option for the can't ventilate, can't oxygenate scenarios.